2 मिनट है। नहीं ना, नहीं हुई। वो इन्होंने स्टार्ट में तो लिखा हुआ था, ईमेल की थी कि 12th को है, मगर कंफर्म मुझे नहीं पता। तो फिर उसके बाद कुछ नहीं बताया।
I think we should start now.
Assalamu alaikum. I hope all the attendees are here. I am Professor Dr. Sumbal Tariq. I am the chairperson of pharmacology at AU Medical College, Aptabad. And it is my pleasure to be invited to say something about antimicrobials. As you can see, I'm basically MCPS and FCPS medicine. And by my own choice, I've joined the basic side because that was my passion. And hope a lot of you can join me in this field. It's a very, very satisfying field. Today, we'll be discussing the antimicrobial drugs. And basically, antimicrobials, whenever we are talking about antimicrobials, we are talking about chemotherapy. So therefore, I'm going to start off with the definition of chemotherapy, which is defined as the use of synthetic, semi-synthetic, and naturally occurring chemicals to kill or suppress the growth of specific organism causing infectious diseases. In this slide here, I've put in nearly a lot of things that may help you. But because of the shortage of time, I'll just go on to discuss something about antibiotics instead of going into the commensals and everything, because a lot of bacteria are surrounding us all the time, and they are the ones which cause all the infections. और बैक्टीरिया के साथ साथ ऐसे आपको पता ही है आजकल कि chemotherapy को अगर generally हम करें तो we also include in this agents that show effectiveness in the treatment of cancer. ठीक है? तो cytotoxic drugs और chemotherapy को हम एक ही जगह, that's why we should do it like this कि हम उसको साथ-साथ पढ़ें when you are preparing for exams. But like I just told you, we are pressed for time, so I'll just go on to discuss the antibiotics themselves. इसमें मैंने बहुत सारी slides ऐसी डाली हैं कि if you'd like, you can go on to look at them, and you'll find out what is the basis of disease and how we have to protect our patient and ourselves from the disease. तो इसमें bacteria, fungi, viruses, ये सब चीजें basically cause करती हैं. Then there are differences in the bacteria, differences in the hosts, and all of these are responsible for the various infections. And we have to be very, very clear of our basic pharmacology as well as physiology of the bacteria when we're thinking of treating anyone with an antimicrobial. Antimicrobials have been used for a very long time. यहाँ पे तो जो सबसे पहला हमने क्या है तो वो protonil थी एक dye, and from this dye we got sulfonamides which came to the market 1929 approximately. और फिर penicillin 1941 Fleming का वो observation in his culture कि there was suppression of growth around the fungus, और उसने फिर वहाँ से penicillinum mold जो था उससे penicillin isolate की, और 1941 में it was in the market treating patients. Before that, it was a very, very dark time because infections were lethal mostly. और इसमें हम क्योंकि penicillin से ही start हुआ करीबन ये सब सफर, और sulfonamides were the ones which are available even before that. तो ये दोनों drugs जो हैं, they are still being used and they are the drugs of choice in many infections. मगर इन सबसे पहले you should have a basic knowledge of the bacterial cell wall, जो कि I'm sure कि तुम लोगों को कर दिया हुआ है इसमें pathology में सब lectures हो चुके हैं. But इसमें gram positive, negative bacteria को identify करना, ये देखना कि which antibiotic will be best for which infection. I myself was a trainee, not a very long time ago, ऐसे ना कहूँ. तो in that time I learned कि interactive type table जो है, that is the best thing. The best thing to do would be, first of all, when you are reading antimicrobials, you should first of all know which bacteria we are going to target when we are giving them antimicrobial. And for that, you have to make a table of gram-positive bacteria, gram-negative bacteria, aerobes, anaerobes, और इसी तरह आगे फिर उनकी ड्रग ऑफ चॉइसेस एक दफा आप शुरू में लिख लें और इन्फेक्शन वो कौन सी कॉज करते हैं. Then whenever you have done that, then you will come to this next step कि कौन सी antibiotic use करनी है. For me, the easiest way of remembering antibiotics was that we should start with how antibiotics will act. ठीक है? तो classification of bacteria वगैरह करने के बाद making a table in which you can point out कि कौन सी infections वो cause कर रहे हैं और उसके बाद ये ascertain करने के बाद कि which antibiotics are at your disposal, you can start treating the infections. ये सारी slides इसीलिए मैं skip करती जा रही हूँ, but you will have them available because I'll share this slide with you, and you should go over these in conjunction with what you already learned from your pathology. तो इसमें antimicrobial agents पे जब हम आ जाएं, because after all that basic knowledge that you already gained, so they are the most widely prescribed drugs in the world. And like I said, sulfonamides were the first antimicrobial agents, and protonosil is a dye. और उससे इनको 1936 में it was found out कि sulfonamides could be used as an antimicrobial agent. Penicillin 1941 में, जैसे मैंने भी आपको कहा, यूज की गई. और drugs derived from living organisms, which are mostly fungi, used to kill or suppress the growth of microorganisms, which in this case are bacteria, are known as antibiotics. मगर मैंने शुरू में आपको एक concept दिया है, which is chemotherapy. Chemotherapy includes not only the antibiotics, which are derived from the living organisms and used to kill or suppress microorganisms like bacteria. Chemotherapy का मतलब ये है कि you include everything. आजकल bacteria से ज़्यादा आपको पता है viral infections का दौर चल रहा है. Then fungi are also there. Then helminths, and also ये जो plasma आजकल hemorrhagic fevers, ये भी सारे mostly antivirals इनमें effective होंगी. और इसके अलावा you also have to look for the protozoa which are causing infections. And lastly, but most important, you should also in chemotherapy know about the cytotoxic drugs. तो antimicrobials की अगर सिर्फ मैं बात करूं तो उसमें they show selective toxicity and they have a specific mechanism of action. And let's talk a little about the mechanism of action and how we can stop infections. इसमें there's one classification of antimicrobial drugs which states that कुछ antibiotics are bacteriostatic and some are bactericidal. Bacteriostatic, as the name indicates, are a group of antimicrobial drugs which will cause a stasis in the multiplication of the bacteria, but they will not kill the bacteria completely. So because they will just slow down the multiplying process, they'll even take it to a standstill. But for killing a bacteria, we'll need one of the bactericidal drugs. And this concept has to be known to be able to treat an infection perfectly. Bacteriostatic may we have tetracyclines, sulfonamides, trimethoprim, lincomycin are example of bacteriostatic drugs. They will just stop the infection in its tracks for some time. And for this, remember, we need a bacteria which is constantly multiplying. अगर bacteria पहले से multiply नहीं करे, तो you can't take them to a standstill. Chronic infections में इसीलिए ये वाली drugs इतनी अच्छी नहीं हैं. Active multiplying bacteria को bacteriostatic drugs जो हैं वो treat करेंगी. But for the real treatment of any infection, we should use bactericidal drugs, जिसमें penicillins, cephalosporins, vancomycin, aminoglycosides, and quinolones are the most commonly available ones. Here, like I said, another classification that you should think about when you are doing antimicrobials, okay, what do you want? Which spectrum do you need for the drug that you're going to treat? इसमें narrow spectrum का basically मतलब होगा कि थोड़े से बैक्टीरिया, जब आपको मैं कह रही हूँ टेबल बनाओ, उस टेबल में थोड़े से बैक्टीरिया इनमें आ जाएंगे कि ये स्टेफ है, ये स्ट्रेप्टोकोकस है, ये जो ग्राम पॉजिटिव रॉड्स को ट्रीट करेगी, ये ग्राम नेगेटिव को करेगी. तो नैरो स्पेक्ट्रम में वी हैव पेनिसिलिन G and V. Again reminding you, penicillin is our वो वाली drug which was discovered first of all and came into the market first of all. Magar it was not enough. That is why we had such a huge myriad of new drugs available in the market. Here we have oxacillin. Oxacillin penicillinase जो resistant penicillin bacteria थे, वो उन्होंने क्योंकि produce करना शुरू कर दिया अपनी बनाने के लिए resistance, तो oxacillin came to the market. Then we have vancomycin, which is from another drug group. Isoniazid, the most commonly used drug, especially for as an anti-TB, and fusidic acid, which is specifically used for topical infections. Extended spectrum antibiotics will be drugs which will cover a wider range of bacteria. Ampicillin, amoxicillin, carbapenicillin. Then we have all three of these are penicillins. Then we have cephalosporins, amikacin, and gentamicin, which are aminoglycosides. Then we have broad spectrum antibiotics. Broad spectrum antibiotics की tragedy हमेशा से ये रही है कि they've been used by everyone at all times, and therefore they have had resistance from the bacteria built up against them, and therefore they are not very commonly used for patients. जैसे अगर मैं tetracyclines broad spectrum में सबसे पहले मैंने डाली हुई है, तो tetracyclines, do you know, are used normally also in poultry farms, in animal husbandry, and इतनी ज़्यादा tetracycline use हुई है कि now bacteria have developed nearly absolute resistance against them. Or there are basically 5 ways in which resistance can be made against these antibiotics that we give to the patients. और जो bacteria हैं, all 5 ways से tetracycline के against they have produced resistance. Then another broad spectrum one is chloramphenicol. Or chloramphenicol, again, chloromycetin, chloramphenicol was a drug used very, very commonly against typhoid fever, or it has other wide spectrum of activity. Again, इसके against भी बहुत ज़्यादा the bacteria have produced resistance. With cotrimoxazole. Cotrimoxazole is a sulfonamide, और इसके against भी बहुत ज़्यादा आहिस्ता there is immune resistance from the bacterial side. Then fluoroquinolones, which are the latest group of drugs which have come into the market. Latest का मतलब है मेरी तरह का latest, that is 1980s, 90s. And they have also, there's a whole group of them, first से second से third से fourth generation बनती जा रही हैं drugs की. And bacteria have been very, very resistant to the first generation by now. Second generation को भी resistant होते जा रहे हैं, and they are drugs of choice in a lot of infections. So what I mean to say is that whenever you are using antibiotics, you have to be very, very clear कि आप कौन सी infection को treat कर रहे हैं, और therefore before you start giving an antibiotic, if you are not careful and if you do not give the proper dose, so giving antibiotics is useless. So number one, general rules for antibiotic use में, you have to identify the organism before antimicrobial use. अब होता क्या है, you will get a patient who has a sore throat, सबसे common हमारा आजकल, तो first of all you will have to identify कि ये sore throat किसकी वजह से हुआ. Now if you look at the reasons, the bacteria which can cause a sore throat, so we have streptococcal infections, even it can be streptococcal, फिर H influenza भी हो सकता है इसमें, और जितने नाम लो सारे bacteria involve हो सकते हैं. तो therefore you have to identify the antimicrobial that can be used for that specific organism. और इसके लिए basically करना क्या चाहिए, you do not start the treatment at all before you take a culture sensitivity test. अगर आप culture sensitivity के लिए let's say throat swab नहीं ले रहे हो and you just prescribe an antibiotic, so maybe you took the wrong way, because you've already given the patient an antibiotic and the bacteria which were there have not been identified, and they can produce resistance to that antibiotic and all of its group. So therefore, start treatment with narrow spectrum antibiotics after taking the culture sensitivity. Waiting for culture sensitivity results, especially if the infection is severe, you can give the coverage for gram-negative, gram-positive, and anaerobic infections, that is broad spectrum antibiotic आप जो है उसको patient को start कर लेते हो. As I'm talking about upper respiratory tract infection right now, that means acute pharyngitis की मैं बात कर रही हूँ, sore throat की बात कर रही हूँ, तो let's say कि हम उसको erythromycin पे डाल देते हैं. Let's say कि हम उसको ampicillin या moxicillin या augmentin पे डाल देते हैं. Whatever we do, we should take the culture sensitivity test before giving the antibiotic. If you start off the antibiotic, then you have to wait for 48 hours after stopping the antibiotic to take that test. And फिर भी हमेशा क्या होता है कि culture sensitivity, if you did not do it before starting the infection, then it will come out as negative. Then after the culture sensitivity result comes, so you have to change the antibiotic according to culture sensitivity results. Patient mostly comes to you second to third day after infection. जब वो सही बीमार होते हैं तो they'll come to you and you start them. You are a good practicing doctor. You started them on an antibiotic after taking the culture sensitivity. Send the culture sensitivity to a lab. So what will happen is 48 hours और गुजर जाएंगे by the time the culture sensitivity result comes. तो 5 days approximately infection के गुजर गए. अब 5 days के बाद, if the patient is better, so you can just continue with your broad spectrum antibiotic that you started it, and maybe the patient will be well enough to not come back to you. But otherwise, if he's serious or the patient is deteriorating, so antibiotics should be given according to the culture sensitivity results. Antibiotics की एक और बात which we have to be careful about, they should be given the proper dosage for the appropriate duration of time. ये नहीं हो सकता कि आप patient को कहो कि take let's say कि ampiclox 500 milligram 3 times a day, that is 8 hourly, and he just takes it when he feels like it. एक दफा ली, दूसरी दफा नहीं ली, तीसरी दफा ले ली. What happens if the patient does that? The minimum inhibitory concentration of the antibiotic falls when the patient does not take it at the appropriate duration, and therefore the bacteria have time to cause a resistance to that antibiotic. Okay? And secondly, let's say the patient takes it for 3 days and the symptoms are there, though they have improved. If he stops the antibiotic without your approval, or you ask him to just take it for 3 days, so the patient doesn't recover fully, and as soon as the antibiotic is stopped, the infection reappears. Therefore, antibiotics पे आपने stress करना होता है कि they have to be given in proper dosage and for the appropriate duration, because minimum inhibitory concentration of the bacteria for that antibiotic has to be maintained. Pus or foreign body, या necrotic tissue, if it is present, the concentration of the antibiotic in that pus or foreign body or around the foreign body, if it is necrosis, it will be 0. Because antibiotics have to be distributed to the various parts of the body, and if pus is present, foreign body or necrotic tissue is present, you have to remove it before starting the infection. Therefore, the importance of incision and drainage, especially whenever there is abscess formation, you have to incise and drain that portion, and local dressing is the best thing to do besides antibiotics. Here, bactericidal drugs are used whenever host defense mechanisms are inadequate. अगर तो patient की अपना इतना ज़्यादा immunity हो कि they can overcome normal infections, जैसे viral infections का it is said कि none of the viral infections will last beyond 21 days. ठीक है? 21 days के बाद आप कुछ करो या ना करो, viral infections will go away. Bacterial infections though can last longer, especially if you think of tuberculosis. तो ये years पे last कर सकती है. तो whenever you decide कि आपने bactericidal drugs use करनी है out of the antibiotics, you have to also look at the host and the age of the host, the fact that the host is immunocompromised due to some other diseases, जो syndrome X हम कहते हैं, diabetic, hypertensive, obese patients. अब ये सब के सब वो patients हैं जिनमें आपने ये पहले से ही you have to think that the host, that patient has depressed immunity. Agar there is any history of any TB or any cancer, then the patient again is someone who does not have adequate immunity, and you have to aid him by giving the bactericidal drugs. Severe infection and resistant organisms में we have to give 2 or more drugs. Severe infection का मतलब ये है कि लाइफ थ्रेटनिंग टाइप इन्फेक्शंस अगर हैं या रेजिस्टेंट ऑर्गेनिज्म का आपको पहले ही आइडिया हो गया कि ये पेशेंट हैज कम टू यू एंड ही हैज बीन ऑन एंड ऑफ एक ड्रग ली, बोला मुझे टाइफाइड था, somebody gave him let's say कि ciprofloxacin, which is one of the fluoroquinolones, and after 3 to 5 days he stopped taking it. When in typhoid, minimum bactericidal inhibitory concentration रखने के लिए fluoroquinolones में से ciprofloxacin still remains a drug of choice, though it has resistant organisms all over the place, but the dose would be 750 to 850 milligram 3 times a day up to, and you have to give it for 2 to 6 weeks. अब वो जो 5 दिन के बाद आपके पास आ जाए तो it is no use again using the same drug, or you have to start him on something different. इसी तरह TB, tuberculosis, which is one of the commonest infection in our part of the subcontinent, इसमें क्या होता है कि you have to give them upfront 3 to 4 drugs for the initiation phase, and after that you can shift to up to 2 drugs for the maintenance phase. मगर अगर आप 2 या more drugs नहीं देते, the patient develops multi-drug resistant tuberculosis and will keep on coming back to you. Then drugs should be properly selected for combination therapy. इसका ये मतलब है कि you have to fire from all sides at the organism. अगर आप सिर्फ कुछ चीजें select कर लो कि ये let's say कि इस patient को tuberculosis है और we'll just give him isoniazid or just give him isoniazid and rifampicin, so these 2 drugs will not be adequate for the initiation phase. You have to give a proper combination of 4 drugs. Pyrazinamide भी add on करनी है. Sometimes you have to give them injections, streptomycin also, and you also have to keep on giving those drugs for a specific time. 2 to 3 months शुरू के is very important. मगर maintenance भी बहुत important है. If you stop the drugs और जो drug combination थी उसको कम कर दिया, ठीक है, 2 drugs भी ले गए, just giving them isoniazid and rifampicin now, you stopped pyrazinamide and streptomycin, or pyrazinamide, streptomycin and all of the other drugs, you still have to make sure the patient is improving. अब ये improving के लिए you have to do certain tests, keep the patient compliant. सबसे बड़ी बात ये भी है. फिर combination of bacteriostatic and bactericidal drugs should be avoided. Why? Because when you give a bacteriostatic antibiotic, the patient's bacteria are brought to a standstill by the bacteriostatic drug, and bactericidal drugs basically are going to kill the bacteria. अब अगर आप उसको bactericidal drug दे रहे हैं and you're killing the bacteria, तो bacteriostatic drug अगर वहाँ dividing bacteria है ही नहीं है, तो it is not going to have any effect. ठीक है, तो you're just burning the patient and it is not really good enough. Antibiotic concentration at site of infection is very important. To be effective, antibiotic must reach the site of infection in amounts above the minimum bactericidal concentration or minimum inhibitory concentration for the infecting organism. ठीक है, so we'll go on. I think from here to these are the definitions of the minimum inhibitory and minimum bactericidal and how to see them, and these are for you कि आप बाद में you can go back and have a look at them. So factors affecting antibiotic concentration में we have dose and duration, route and time of administration, distribution of the drug पे नजर जरूर रखनी है. If you want the drug to be distributed across the blood-brain barrier, give them drugs which are lipophilic. You have to give them drugs which cross the especially meningeal irritation में, like penicillin does cross the blood-brain barrier, but normally it doesn't. Patient compliance is a very big thing. Compliance का मतलब क्या है कि the patient takes the drugs on time, and if you have a patient who is not compliant, giving him any sort of drug is just an invitation for the bacteria to become more and more resistant to drugs which are available. As I think I shall go on to the mechanism of action of the various antibiotics available in the market. तो ऑन द बेसिस, अभी मैंने आपको बताया कि हमने ऐसे किया कि बैक्टीरियोस्टैटिक होती है एंटीबायोटिक्स, बैक्टीरियोसाइडल होती हैं। हमने ऐसे किया कि नैरो स्पेक्ट्रम एंटीबायोटिक्स अवेलेबल है मार्केट में एंड ब्रॉड स्पेक्ट्रम अवेलेबल है। नाउ द बेसिक way of remembering antibiotics would be to look at the mechanism of action of the drugs. और इसमें mechanism of action of drugs की basis पे इनको classify करना, इनको याद रखना is much more easier. I'm not saying it is the best way to treat a patient. I'm just saying from pharmacological point of view, it is better to know all the drugs and you can classify them into these groups. So basically, they are drugs which cause inhibition of the bacterial cell wall synthesis and cell wall synthesis inhibitors में, as you probably know, we have penicillins, cephalosporins, and monobactams. ठीक है? All of them cause inhibition of the bacterial cell wall, और the inhibition का जो mechanism है, उसको थोड़ा सा याद रखना important है, but when transpeptidase in उनकी जो वो है transpeptidation of the cell wall, उसको inhibit करती हैं, and penicillins, cephalosporins, monobactams. These are the ones who specifically do it. Then inhibition of the cell wall. Inhibition of the cell wall is trionem वगैरह. They call cell membrane. आपको पता है कि cell wall is the solid type of cell wall. Peptidoglycans की cross linkages के साथ बनी हुई होती है. और कुछ bacteria do not have a typical that solid cell wall. They just have a cell membrane. तो उनकी भी inhibition जो है वो कुछ एंटीबायोटिक्स ऐसी हैं जो उस पर बेस्ड हैं और उनका मैकेनिज्म ऑफ एक्शन ये है कि वो इनहिबिशन ऑफ द सेल मेम्ब्रेन करेंगी. देन देयर आर अ होल होस्ट ऑफ एंटीबायोटिक्स व्हिच कॉज इनहिबिशन ऑफ प्रोटीन सिंथेसिस. द बैक्टीरिया नीड न्यू प्रोटीन्स एंड दीज न्यू प्रोटीन्स आर अवेलेबल टू देम थ्रू द प्रोडक्शन इन द राइबोसोम्स. और राइबोसोम में 30 और 50S यूनिट में वो डिवाइड हुई है और जो हम डिफरेंट एंटीबायोटिक्स देते हैं वो डिफरेंट जो सब यूनिट्स हैं उनमें जाके प्रोटीन सिंथेसिस ऑफ द बैक्टीरिया रोकती हैं. आई गो इनटू दिस अगेन. फिर एंटीमेटाबोलाइट्स. दे आर ड्रग्स व्हिच बेसिकली कॉज अ डिक्रीज इन द एक्टिव प्रोडक्शन ऑफ ऑल द मेटाबोलाइट्स ऑफ द बैक्टीरिया. ठीक है? इसमें स्पेसिफिकली सल्फोनामाइड्स की जो है वो एग्जांपल है. देन इनहिबिशन ऑफ न्यूक्लिक एसिड सिंथेसिस. फ्लोरोक्विनोलोन्स आर द वंस स्पेसिफिकली जो ये करती हैं कि वो न्यूक्लिक एसिड सिंथेसिस ही नहीं होने देती, डीएनए आरएनए जो है इनको बनने नहीं देती. देयरफॉर द बैक्टीरिया कैन नॉट डिवाइड एंड दे कैन नॉट कॉज फर्दर इन्फेक्शंस. देन सेल वॉल सिंथेसिस इनहिबिशन की बात अगर हम करें तो बैक्टीरिया पोजेस हाई इंटरनल ऑस्मोटिक प्रेशर. और हमारी जो बॉडी फ्लूइड्स है, मेमेलियन बॉडी फ्लूइड्स की हम बात करें ह्यूमंस की, तो हमारा जो ऑस्मोटिक pressure है वो different है from them. It is lower than the bacteria. Intact cell wall will prevent the movement of fluids inside the bacterium. अगर उनकी cell wall intact रहेगी तो body fluids जो हमारे humans के हैं वो bacterium के अंदर enter नहीं हो सकते. Inhibition of cell wall synthesis leads to the movement of water into the cell और this causes cellular swelling and lysis of the bacterium. यानी इनहिबिशन जब भी आप सेल वॉल की सिंथेसिस करेंगे तो देयर इज मोर पोर फॉर्मेशन, पोरीन्स छोटे छोटे बन जाते हैं एंड फ्लूइड फ्रॉम द ह्यूमन बॉडी मूव्स इनटू द बैक्टीरिया व्हिच कॉजेस द स्वेलिंग एंड लाइसिस. Penicillins, cephalosporins, monobactams are all inhibitors of cell wall synthesis. ठीक है? This is how they have their antibacterial effect and they will call a bactericidal effect because they'll kill the bacteria. Then inhibition of cell membranes. तो bacterial cell wall, चाहे वो gram-positive bacteria and negative हैं, all of them are lined by cell membrane, and this controls the internal environment of the bacterium. जहाँ कहीं भी there is disruption of cell membrane or alteration to the cell membrane permeability, this will also cause bacterial cell damage. That means that whenever you give an antibiotic and it can go and disrupt the cell membrane, it causes permeability to increase or causes bacterial cell damage and death occurs. Polymyxins, which are typically used in our dermatological preparations, polymyxin mostly उसके लिए use होती है, otherwise it is very very toxic और हम systemic उसमें नहीं देते. It damages the cell membrane of bacteria and leads to escape of metabolites, ions and proteins from the bacteria and causes cell death. Then inhibition of protein synthesis. इनिबिशन ऑफ प्रोटीन सिंथेसिस में बैक्टीरिया और राइबोसोम्स जो है वो उसमें 30 और 50 S subunits होती हैं. Various protein synthesis inhibitors bind preferentially to different subunits. Aminoglycosides और tetracyclines जो हैं ये 30 S subunit के साथ bind करती हैं और they cause the effect. While macrolides and chloramphenicol typically they cause a decrease in the synthesis, protein synthesis in the 50 S unit. I'll just go back a little because I had a diagram on this, which will be better to explain what I'm saying. I'm sure you've read a lot about these things, but just a second. I'm sorry, I wanted to go back to one of my slides. The worst way was, just a second. Okay, if we look at this slide, just a second, let me maximize it. Okay, this is basically the ribosome in the bacteria. It is called 70S unit. Isme we have two portions, the 50S portion and the 30S portion. Basically, messenger RNA, when it comes from the bacteria, they start replicating to messenger RNA, they send in the messenger RNA or say transcription RNA is formed. And this is the 50S portion which formed that. So there's a growing polypeptide chain. 50S पे chloramphenicol and macrolides are the ones which have an effect. Chloramphenicol inhibits the formation of the peptide bond, and therefore there is a decreased production of the proteins necessary, and therefore there is decrease in the protein formation in the bacteria, and the bacteria which were growing, they need the protein formation for their normal growth. It doesn't occur, and therefore the bacteria die off. Erythromycin is one of the macrolides, and this prevents the translocation of the protein, and again protein formation is decreased. Then 30S subunit means specifically tetracyclines, they interfere with the attachment or miss codon reading karta streptomycin by acting on the 30S portion. So this is how the various bacteria have their effects, and they cause a decrease in protein synthesis by the bacterium. And when there is decreased protein synthesis by the bacterium, there is decreased production of all the things that are present, and therefore it causes a decrease in the replication of bacteria, and therefore we have bacteria which are not stable enough to resist the antibiotics we are giving them. I was talking about the mechanism of action of antibiotics, and in this I have told you that antibiotics may, number one, cell जो wall synthesis inhibitors होते हैं वो हैं. Number two, we have cell membrane inhibitors. Number three, we have bacteria which cause a decrease in protein synthesis, inhibition of protein synthesis. I was trying to explain that. And now we'll go on to the fourth type of antibiotics available. And in this, we have the antimetabolites. An example of the antimetabolites are sulfonamides. Sulfonamides may, basically, as you know, bacteria synthesize folic acid from paraminobenzoic acid. And the synthesis of folic acid from paraminobenzoic acid is essential because folic acid is required for the synthesis of the nucleic acids of the bacteria, DNA and RNA. Therefore, sulfonamides and trimethoprim, they inhibit the synthesis and utilization of folic acid by bacteria and suppress their growth. They cause a decrease in tetrahydrofolate reductase enzyme पे जाके ये act करते हैं sulfonamides, and they cause a decrease in the replication of the bacteria, and therefore they are specifically bacteriostatic. Then we have another mechanism by which some of the antibiotics act, and in this they cause inhibition of nucleic acid synthesis. Nucleic acid synthesis को जो decrease करते हैं bacteria, उसमें we have rifampicin, which is anti-TB drug, and quinolones. Quinolones they go and act at the DNA as DNA gyrase inhibitors. What happens is that supercoiling of DNA is needed, or अगर ये supercoiling होती है तो the DNA splits into two and daughter nuclei जो हैं वो form हो सकते हैं. But they cause inhibition of DNA gyrase, or by doing this, they cause a decrease in the splitting up of the various bacteria into their daughter nuclei. And whenever the daughter nuclei do not form, they kill bacteria. Rifampicin, which is one of the anti-TB drugs, also acts in a similar way. It causes decreased inhibition. It causes inhibition of the nucleic acid synthesis. Then we have, I'll talk something about bacterial resistance. Like I told you before, bacterial resistance is something which is a big challenge for clinicians. And this develops because the bacteria are rapidly growing cells and they infect us over time. हर एक को ही infection होती है. Basically, antibiotics were formed, and a lot of them keep on coming into market because we need antibiotics for our safety. There are different types of infections present. एक तो natural bacterial resistance है. Natural bacterial resistance जो है उसमें antibacterial agent has no effect on that bacteria. Let's say कि अगर हम उसको bacteria को we are giving a certain antibiotic from gram-positive infection, we give aminoglycosides. So they have no effect on gram-positive bacteria. Aminoglycosides typically will cause the bactericidal effect on gram-negative bacteria. So if we use the wrong antimicrobial agent, so they'll have no effect on the bacteria, and therefore the infection will go on and be lethal. So natural resistance is the best thing, is the first thing that you should know. Then we have acquired resistance. इसमें the antibacterial agent is effective against the bacteria, but the bacteria develop defense against the antimicrobial agent. Now, acquired resistance के लिए, what is needed basically is कि आप minimum inventory concentration से, if the antibiotic you're giving is falling below that concentration, number one. Number two, if the patient who is receiving the antibiotic is non-compliant, वो आगे पीछे कर रहे हैं अपनी डोज को और ज्यादा टाइम दे रहे हैं बैक्टीरिया को विदाउट एंटीबायोटिक कि वो बिल्कुल मिनिमम डोज पे वो अपने आप को छोड़ देता है, तो the bacteria have time to develop resistance. And usually all of the acquired resistance that develops and is developed by the bacteria against the antimicrobial agent is plasmid derived. ठीक है, तो mechanism क्या होता है कि number one, the bacteria may suddenly change its wall. The wall of the bacteria, if it changes its consistency, जैसे मैंने कहा कि protein, penicillins and cephalosporins and monobacteriums will go and bind at specific penicillin binding protein, या cephalosporin binding protein on the wall. So if the chemical nature of that binding protein or receptor एक तरह का ना, it changes, then the drug will not be able to bind to it, or the bacterium causes its outer membrane to become more imporous. ये उसको penetrate ही ना कर सके, and then there will be inability of the drug to penetrate the cell wall. And even if it penetrates the cell wall, the receptor protein's configuration has changed and it will not go and bind to the receptor. Therefore, the bacteria will become safe from the antibiotic. Synthesis of enzymes by microorganisms that destroy the drug. Isme we have staphylococcal infections in which the staphylococcus starts secreting penicillinase, which destroys the penicillin structure. So beta lactamases produce करना शुरू कर देते हैं, and the beta lactamases enzymes produced by these microorganisms, they'll go and they'll destroy the penicillin. और जब उसकी वो destroy कर देते हैं, तो there is no effect of that penicillin on these bacteria, and they can also cause changes in the structure of DNA. The structure of the DNA will change so that the drug which was meant to go in case of fluoroquinolones was meant to go and cause DNA gyrase inhibition. And there's such a change in the DNA of the microorganism that it has no effects. Here, the bacteria can also cause changes in the metabolic pathways that bypass the reaction inhibited by the drug. Like I said, tetrahydrofolate reductase is the enzyme. Sulfonamides will have a inhibitory effect, and therefore folic acid production will continue as normal. और ये that is how sulfonamides की resistance produce की गई है by the bacteria. They have a change in the metabolic pathway. Then another way would be that because the bacteria, they have a mutation or gene encoding of inactivating enzyme target protein और transport protein सबके सब जो हैं उनको change कर देते हैं. Gene mutation जो हो जाती है, तो when the macrolides goes to the ribosome and wants to bind to a certain translocation protein, it is so changed it can't recognize it. The resistance is acquired by the bacteria by mutation to gene encoding और inactivating enzyme target protein या transport protein जिस पे bacteria में वो drug transport हो रही थी, वहां से वो transport ही नहीं हो सकती. फिर resistant gene R factor may be passed vertically to daughter cells. तो daughter cells जो अब नई resistant bacteria बन रहे होते हैं, उनके जो daughter cells produce होते हैं, सब के सब में resistant gene चल पड़ता है. And even if after that you give them a continuous dose of the antimicrobial, it doesn't have any effect. More commonly, resistance is acquired by horizontal transfer of resistant determinants from one bacterium to another or by transformation, transduction and conjugation. यानी सारे के सारे जितने भी नए बैक्टीरिया प्रोड्यूस हो रहे होते हैं वो ऐसे होते हैं कि जिनमें there is no effect of what you are giving them. Transformation का मतलब है incorporation of resistance gene that lie free in the environment into the bacteria. Transduction का मतलब है transduction takes place through the bacteriophage, and conjugation passage of gene from cell to cell by direct contact with the sex bridge. So all three of these can cause a different production of daughter bacteria, which will have no effect, and therefore resistant किस्म की bacteria होंगे. And even if you give them everything, the best antibacterial possible, they'll have no effect on the infection, and the infection can lead to lethal effects. The properties of a good antibacterial antibiotic. What are the properties when you are looking for an antibiotic which would be the best to give to a patient? It should be safe. That means it should be least toxic. Aksar antibiotics, when I'm telling you about this adverse effects, you'll find out that all drugs have side effects. Okay? But some drugs also have adverse effects and toxic effects. So whenever you are choosing a good antibiotic, you have to choose a drug which should be safe for the patient and should be least toxic for that patient. If I give you an example, penicillin, again, the first group of antibiotics which came into the market, it is very safe if you consider it with the other antibiotics available. Magar, at the same time, in people who have anaphylactic reaction to it, can be toxic, it can be lethal, it can kill the patient. So therefore, what is safe for one person may not be that safe for the other. You have to individualize कि किस patient में आप कौन सी antibiotic दोगे after knowing कि आपने कौन सी bacterium को आप target कर रहे हो. Then the antibacterial drug should have convenient dosage regime. अगर एक antibiotic आप दे रहे हो, and again I'll give you the example of enteric fever, which is typhoid fever. So the drug of choice for typhoid fever over time has changed. पहले it was chloramphenicol. Chloramphenicol के कैप्सूल होता था 250 मिलीग्राम का, क्लोरमाइसिटीन का कैप्सूल या 500 मिलीग्राम का, and the normal anti-typhoid dose which had to be given was 2 capsules 250 milligram wale every 4 hours. Imagine a patient who has typhoid fever and you have to give him 2 capsules every 4 hours, up to 6 times a day for 2 to 3 weeks. तो एक पेशेंट जो पहले से एनोरेक्सिक है, इसका पहले से ही तबीयत बहुत खराब है, how will you give it? But that preparation is pretty cheap if you come to the economy of it. But at the same time, after some time, we had ceftriaxone, which is a third generation cephalosporin, and can be given as injectable, or now we have cefixime, which is a fourth generation, which can be given orally. Of ceftriaxone, 1 gram twice a day, आपने patient को देनी है for typhoid fever. And mostly it is very effective. 3 to 5 days के बाद, the patient gets better, and you can shift them to the fourth generation cefixime tablet. Or that has to be given once a day, or the patient gets very well. That is expensive, number one. Number two, you have to take the patient for the initial 3 to 5 days for injectables. Then we have another drug, which is ciprofloxacin, drug of choice for typhoid. And you give that patient 750 to 850 milligram, yani 500 milligram to 2 tablets if you give it twice a day for 2 weeks or 3 weeks. So it cures the patient very well if the patient is compliant. Again, there are dosage ka problem yahan pe bhi kabhi lagta hai. Then the patient is pregnant and has typhoid fever. Now the drug of choice would be amoxil 500 milligram, and you have to give it 3 times a day for 3 to 4 weeks. So you have to give the patient the most convenient dose regimen for that patient. अगर बहुत poor patient है, तो I'd still go for chloromycetin की बजाय इसके कि उसको दवाई ना दें, chlorphenicol दे दें. अगर affording है, hospital में शुरू में admit हो सकता है, तो ceftriaxone followed by cefspan would be good enough. अगर वो at home कर रहा है और फिर हम one of the macrolides भी दे सकते हैं, तो Azomox दे सकते हो. There's lots of drugs now, and you have to choose the best one which will suit that patient, have a convenient dosage regime, and you have to keep in mind, okay, the antibacterial drug should have a low minimum inhibitory concentration and a minimum bactericidal concentration. If they are not a minimum, if you have to increase the dose to provide that minimum inhibitory concentration, then as you increase the dose of drugs, the side effects and in turn toxic effects also increase. So we have to be very careful. Then the drug that you are giving, the antibiotic that you are giving, should be effective against the causative agent. अब आप किसी को गलत drug दो, like अभी मैंने थोड़ी देर पहले कहा कि anaerobic infections, let's say के हैं, and you have to cover anaerobes, and you start giving them just a drug which covers the gram-positive portion. कुछ भी नहीं, खाली आप उसको amoxil दे रहे हैं, या आप उसको first generation cephalosporins में से cefridine देना शुरू कर देते हो, and it does not cover the anaerobic portion of the infection or the anaerobes. So what's the use? So you have to give a drug that should be effective against the causative organisms, and then you should achieve effective concentration in the plasma at the site of infection. Site of infection पे अगर you do not achieve the effective concentration, let's say कि tuberculosis में, if it's pulmonary tuberculosis, you need the drug to cover the pulmonary vasculature or the pulmonary पूरी जो tree है उसमें उसको distribute होना चाहिए. If you are thinking the patient has meningitis, tuberculous meningitis, then you have to make sure that the patient's drugs should reach the CSF. अगर वहाँ नहीं पहुँचेगा, तो how will it treat the infection? और इसीलिए you have to be sure of what you're treating before you start the drug, and you have to be sure कि आप उसको effectively treat कर सकते हो. Or like I said at the start पे, I said if somebody has a sore throat, हमारे time में when somebody has a sore throat, we used to gargle, and we had that throat tincture type thing जिसको directly आप लगाते थे, and 60-70% जो लोग थे, they just be cured by that. Now you have to give them, I don't know how many type of antibiotics which will go and will be secreted into the tonsils, and then they'll cause their effect on the tonsils. So topical देना would be better. तो ये सारी जो है, you have to make sure you are the one who is prescribing to the patient, you are the one who is giving them the antibacterial drug. You should achieve effective concentration either in the plasma, अगर septicemia है, या at the site of infection. Topical infection है, topical drug दें, बजाय going for something which will have to be excreted from the body without having its maximum effect at the site of action. And last but not least, the drug should be economical. आजकल के दिनों में you have to be sure that the patient will be very, very bridge for all those long-term infection treatments. And if he is not that rich in our third world society, we have to give them the best drug possible in a cheaper version. You don't have to go for the multinational company brands. You just have to treat the patient with whatever is best for the patient. Antimicrobial drug combinations can sometimes be given, like I told you beforehand, in seriously ill patients to provide the best and broad spectrum empirical treatment. हमने उनको different type की एक वक्त में 2 या 3 antibiotics पे you have to put them on that. Let's say कि अगर किसी को intra-abdominal abscess है, तो you have to think of gram-positive bacteria, you have to think of gram-negative bacteria, you also have to think of anaerobes. So let's say आप उनको क्या क्या दे सकते हो कि you can treat them with one of the penicillin, yes, cephalosporins की third generation. You also have to add on metronidazole, which is the best choice for anaerobes. You also have to add on one of the aminoglycosides for the gram-negative bacteria. To decrease the emergence of resistant strains, for example, in TB, sometimes you have to go beyond the first-line drugs, or you have to go into the second line. Cyclosporin भी उसको दे सकते हो आप, one of the fluoroquinolones दे सकते हैं. You can give them azithromycin also, macrolides में से, ताकि resistant strain अगर हो ही गया है, तो you have to change the ना सिर्फ आपने combination लेनी है drugs की, तो पहले 4 drug combination of normal TB first line drugs थी, उसकी जगह you have to also go into the second line ones. And sometimes to decrease dose related toxicity, so you have to do polypharmacy also, कि ठीक है अभी ये pelvic inflammatory disease की patient है, तो we'll just give them a little dose of one of the tetracyclines, doxycycline जैसे दे दी, and anaerobes को cover के लिए you can give them metronidazole at the same time. और इसी तरह brucellosis में different चीजों में आपने dose related toxicity को कम करने के लिए 1 की जगह 2 की जगह 3 drugs भी you can prescribe. फिर drug combinations के फायदा क्या होता है? Combinations become more effective, like cotrimoxazole, आपको पता है trimethoprim और sulfamethoxazole की combination है. If you give either of these drugs separately, they don't have a wide spectrum of activity. तो cotrimoxazole given together, तो एक गोली है and it works better. Synergistic effects जो होते हैं, you can get those by combination of beta-lactams and aminoglycosides, and that is 1 + 1 is 3. You have a better control of the infection. Then you can inhibit bacterial drug inactivating enzymes by adding on some of the drugs which are available in the market. For example, मैं कह रही थी beta-lactamase producing जो bacteria हैं, उनके against we have chloronic acid, sulbactam. अब augmentin में we have one of these, and it causes inhibition of the bacterial drug inactivating enzymes. At the same time, आपकी जो penicillin itself है, वो treat कर रही होती है infection को. You can also broaden the spectrum of activity by giving 2 or 3 drugs, like I told you before, and low dose of drugs will be beneficial for the patient, and you don't have to have toxic or side effects coming again and again. ठीक है? फिर use of antimicrobials for the prevention of infections, इसको chemoprophylaxis कहते हैं, and chemoprophylaxis is used especially when you are going for a surgery. Major abdominal surgeries में you should use chemoprophylaxis. Rheumatic heart disease में patient है, you have to use chemoprophylaxis, and endocarditis के patients में again you use chemoprophylaxis. And besides this, जो normal chemoprophylaxis की जब हम बात करते हैं तो हम malaria और इन चीजों की बात भी कर रहे होते हैं, तो we use chemoprophylaxis in those cases also. So I think it says nearly 12:30. I'll end this here. You can go over this lecture, and I wouldn't mind if any one of you wants to ask any questions.